Ma'am is Associate Professor at ABVMS and RML Hospital. Ma'am's area of keen interest are neuroanesthesia and pediatric anesthesia. Welcome, ma'am. The case will be presented by our final year postgraduate student, Dr. Sarvanan. Over to you, ma'am.
Thank you, Dr. Nitin, for the kind words and the introduction. And congratulations to you. I'm meeting you the first time after the results have come out on your remarkable achievement, a very well-deserved one too. We have a very interesting case today, and I hope the students are now awake after the wonderful lunch that they've had. It's a tricky case. It comes very often. Invariably, you will find one such long case in your exams, and we hope that today we shall be able to clear many gray areas. We shall begin with Dr. Sarvanan's case presentation, following which we shall have a Q&A session with me, and then Dr. Sujali will wrap up the session by presenting and giving her wrap up on the particular case. So over to you, Sarvanan. Let's just quickly begin with this. We shall time it in such a way that I'm able to hand over to Dr. Sujali by, I think 2:35 will be fine, Sujali. That gives you 20 minutes.
Yes,
will that
yes.
be okay for you?
Yes, ma'am.
Right. So I'm timing it like that. So give us an hour and 5 minutes. Over to you, Sarvanan. Sarvanan, please unmute yourself.
Ma'am, is my screen visible?
And the screen is visible and we can hear you also now. Go ahead.
Mr. Suresh Kumar, 60-year-old male, a construction worker from Delhi, presented with chief complaints of swelling in the right groin region for 3 years. History of presenting illness. Patient was apparently alright 3 years ago when he developed a swelling in the right groin. It was initially the size of a coin and has gradually progressed to size of a cricket ball, reaching the scrotum over the period of 3 years. The swelling becomes more prominent on standing, coughing, sneezing, lifting heavy object, and disappeared completely on lying down. The swelling is associated with heaviness in the right groin region for the 2 months, which was insidious in onset, mild in intensity. The heaviness or dragging sensation aggravated on lifting weight, coughing, standing, or walking for long distance and was relieved by rest or sitting or lying down position. At workplace was present as he was a construction worker by occupation. No history of chronic cough, difficulty in micturition or defecation. Patient is also a known case of coronary artery disease and hypertension for the past 11 months on regular medication. He gives history of chest pain 11 months back. Following this, he was hospitalized and percutaneous coronary intervention was done with placement of one drug-eluting stent. There was no history of similar complaints after that episode. No complaints of chest pain, palpitation, syncope, breathlessness on exertion, or breathlessness on lying down, or swelling in the legs. He also didn't give history of any weakness in the limb, increased or decreased frequency of micturition, or facial edema. At the time of previous hospitalization, he was diagnosed with hypertension and is on medication regularly for the past 11 months. No history of diabetes mellitus, tuberculosis, jaundice, seizure disorder, thyroid disease, or COVID-19 in the past. He was vaccinated with 2 doses of Covaxin. No history of known allergy or any surgery in the past or significant treatment history other than these. Treatment history at present is on tablet enalapril 5 mg once daily, tablet metoprolol 25 mg twice daily, tablet aspirin 75 mg once daily, tablet clopidogrel 75 mg once daily, tablet atorvastatin 40 mg once daily. Personal history. He is a construction worker by occupation. He has a mixed diet. Was a smoker for the past 20 years who smoked half pack of cigarette per day. He stopped 1 year ago. He is a non-alcoholic. Bowel and bladder habits are within normal limits. Socioeconomic status. He belonged to lower middle class according to modified Kuppuswamy scale. Family history. His father died to some heart-related ailment 5 years back. No history of diabetes mellitus, cerebrovascular accident, or kidney disease running in the family. Ma'am, shall I proceed to examination?
Yeah, just a few points here before you proceed.
Hanji, ma'am.
First, as we discussed previously also, you should never say no history of. You should say no history suggestive of. Because the patient will not say that I have diabetes. Very rarely will the patient be, so well-read or informed to be able to give you a diagnosis. You always say history suggestive of. And we can see till now that he has elicited a very good history from the patient, a good job there. And we can see that this patient had a cardiac event, which was successfully managed by stenting. And then he has been also put on medical management. Now let us see what are the signs after the symptoms. Let us see what are the signs of the disease that we have in this patient. Please go ahead, Sarvanan.
Yes, ma'am. General physical examination. After getting consent, the patient was examined. Patient was conscious, cooperative, well-oriented to time, place, and person. Weight was about 60 kilogram, height 168 centimeter, with BMI of 21.3 kilogram per meter square. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. He is afebrile by touch. Vitals: pulse rate 68 per minute, regular in rhythm, good in volume, normal character, no pulse deficit, no radioradial or radiofemoral delay, all peripheral pulses are palpable and no arterial wall abnormality. Blood pressure 124/72 millimeters of mercury in right upper arm, measured in sitting position. JVP was not raised. Respiratory rate 14 per minute. It was regular and abdominothoracic. He is able to do normal household activities and able to climb 2 flights of stairs, METs greater than 4. Airway assessment: no gross external facial deformity present. Nose, bilateral nares were equally patent. No deviated nasal septum. Mouth, oral hygiene good. Mouth opening of 3 fingers. No loose or artificial or buck teeth. Modified Mallampati class 1. Upper lip bite test class 1. Airway assessment: neck movement normal and full range. Sternomental, thyromental, and hyomental distance within normal limits. Neck circumference 36 centimeter at the level of thyroid cartilage. Examination of the spine. Inspection: no obvious deformity present. No visible swelling, scar, sinus, or pulsation present. Palpation: afebrile to touch, and there was no tenderness. Abdominal examination. On inspection, shape of the abdomen was scaphoid, umbilicus central and normal in shape. No visible scar or palpation. Pulsation: on palpation, afebrile to touch, soft, non-tender, no guarding or rigidity, and no palpable organomegaly. On percussion, tympanic note present in all 9 abdominal quadrants. On auscultation, bowel sounds heard. Local examination of the swelling. On inspection, a right inguinoscrotal pyriform shaped swelling measuring 10 × 6 cm reaching up to the scrotum was present. Swelling appears smooth. Skin over the swelling is normal. No visible scar or pulsation. The swelling reduced completely on lying down. Cuff impulse was present and the penis was deviated to the left side. On palpation, it was not warm or not tender. The shape was pyriform. Size 11 × 8 × 4 cm. It is soft in consistency, expansile on cuffing, and completely reduced. And both tests were felt separately, and I cannot get above the swelling. Zeeman test elicited impulse felt over the superficial ring. On percussion, the swelling had a dull note, and on auscultation, no peristalsis sound heard over the swelling. Systemic examination. Cardiovascular system examination. On inspection, chest wall was bilaterally symmetrical in shape. No visible swelling, scar, or pulsation. There was no precordial bulge. On palpation, inspectory findings were confirmed. Apex beat at the left fifth intercostal space, half a centimeter medial to the midclavicular line. No thrill, parasternal heave. On auscultation, heart rate was found to be 68 per minute and was regular in rhythm. First heart sound and second heart sound appeared normal and no murmur was heard. Respiratory system. On inspection, shape of the chest was normal. Bilateral chest movements equal.
Tell me if there is any positive finding in respiratory system.
No, ma'am. Respiratory system is within normal limits.
Okay. So rest.
Central nervous system examination within normal limits.
Okay. Right. Actually, we are short of time, Saravanan. I think let's come to the diagnosis now. Very good.
Thank you.
Tell me diagnosis.
60-year-old male with a right inguinal hernia, disease, hypertension, post-percutaneous coronary intervention 11 months back is posted for surgery. TEP surgery, ma'am. Total extraperitoneal surgery for hernia repair.
All right. Very good. Now, what are the risk factors in this patient? What are the red flags in this patient? One, you have already said coronary artery disease, hypertension, and post-PCI. In your history and examination, were you able to elicit something else which could be a risk factor in these patients?
Ma'am, he was a chronic smoker also, but he stopped 1 year ago.
Okay, so
And
chronic that sequelae remains, so we are worried about that. Although he has stopped a year back, so that, which is good. Anything else?
ma'am, his age, advancing age,
Yes.
is one
Age
risk
is,
factor.
yes, is also a risk factor. Very good. Now, can you tell me what all investigations would you want in such a patient?
Yes, ma'am. Ma'am, first I'll ask for a baseline hemogram to know the hemoglobin of the patient. So he's not anemic or not, I wanted to know. Then I will order kidney.
Is that the only reason why you want to know whether the patient is anemic or not? What is the cutoff of hemoglobin that we generally take?
Ma'am, 10 grams per deciliter.
Is that not anemia for a young man like you? But we always take up at 10. It would be 10 would be anemic for this patient also. But we take a patient at 10. Why do we keep a cutoff of 10?
Below that, oxygen availability will be decreased below, critical cutoff will be less. So the stress of the surgery could not be met.
So see, the reason for taking 10 is the concept of optimal hematocrit. Blood, we classically say that blood is a non-Newtonian fluid. That means that as the, normally what would happen, the flow rate follows the law of physics, but blood does not follow the law of physics. So what happens here is that as we increase the hemoglobin content, or as the number of RBCs keep increasing, we assume that the oxygen delivery to the tissues should also increase, right? But what happens when the number of RBCs increase disproportionately? The blood becomes more viscous and the flow becomes sluggish. So what is happening, even though the number of RBCs and supposedly hemoglobin content and oxygen carrying capacity is increasing, but because the blood is becoming more viscous, the oxygen delivery to the tissues becomes hampered because of the slow flow. So as you've seen in polycythemia. So 10 is that hematocrit or hemoglobin level at which there is a perfect balance between the oxygen tissue delivery and the hemoglobin content. So that is why we always take 10, even though it is anemic. In a patient with CAD, you have to ensure that the patient is above gram% of hemoglobin. How much is that? Of course, 10 is what we need.
Minimum of 8 gram per deciliter is required.
8 grams is required, and that is also your trigger for calculating allowable blood loss when you're taking up a patient for surgery.
Okay.
Right. So you'll ask for a complete hemogram. What else?
And then I'll ask for a renal function test.
Specifically?
Creatinine, serum creatinine, I will ask.
Okay. Why is that so?
Ma'am, I want to risk stratify my patient, and I will be using RCRA score, and one of the component of it is serum creatinine greater than 2 milligrams per deciliter.
When are you happy? Like, when will you think that this patient is at low risk? At what creatinine level? Or above what creatinine level will you get upset? 2 or anything less than that?
Ma'am, 2.
What do the other multivariate indices take creatinine value as?
1.2, MICA index takes 1.2, serum creatinine cutoff.
So anything above 1.1 is a red flag for us.
Okay.
Right. Okay. Tell me now. You've said hemoglobin, blood count. You've said KFTs. What else?
Ma'am, I would like to have a baseline 12 lead ECG.
Yes. Anything
Then,
else? The biochemical profile, blood investigations. What do you routinely ask for?
ma'am, routinely we order a hemogram, kidney function test, liver function test, and coagulation profile in my institute.
You don't ask for blood sugar?
Random blood sugar is ma'am.
Yes, that's so important.
Yes,
Yes,
ma'am.
diabetes mellitus is again one of your components of RCRI. And why do you
Yes,
want to
ma'am.
ask for a liver function test? Liver function test is not a part of routine investigations at all. None of the recommendations for preoperative advice ask for LFT as a mandatory. And why do you want to go for a coagulation profile?
BTCT I wanted to know because patient is on antiplatelet drugs, and if patient plan for regional anesthesia, I
What
want
is this?
to.
No. Will antiplatelet drugs, do they really do aspirin and clopidogrel really affect the bleeding time? There is a lot of controversy regarding that, and most literature now supports that the in vitro testing is not affected. So you may have a seemingly apparently normal bleeding time and a in vivo raised bleeding profile, coagulation alteration with platelets. So it is not recommended that you go for a BTCT.
Okay.
So you should not look into that. So basically, you're going to look at you will look at a complete hemogram. You will look at urine routine microscopy. You will look at a blood sugar, which is very important. You look at KFT, specifically serum creatinine, as a preoperative this thing. And for cardiac evaluation, you will go for, as you wanted to, as you very correctly said, a 12-lead ECG. Any other investigations? Would you like any more cardiac investigations?
No, ma'am.
Okay, so we'll come to that later. Let's just speak a little bit more about your history. Now, I just want to say one thing in the history that you must always ask for, especially in our Indian scenario, is in the drug history, you should ask about whether the patient is taking any herbal medication or not. Now, in a cardiac patient who comes for non-cardiac surgery, it becomes very important that many patients are taking herbal medicines which contain drugs like herbal medications like ginseng, garlic, ginkgo. Now, all these, they become important to us. You will come across so many of these WhatsApp messages that have these many garlic pods in a day and your blood gets cleared and all that. Now, this becomes important for us because they can lead to contribute to increased bleeding risk in the perioperative period. All these herbal medicines have this problem. So if they are on these herbal medications, one, you should find out, two, they should be mandatorily stopped, discontinued at least 2 weeks before surgery. So that is one thing you need to look into. Now you talked about in your examination, a very important part is assessment of functional capacity. So you said that the patient had METs more than 4, right? So what do you mean by MET?
Yes, ma'am. MET is metabolic equivalent of a task, and it is defined as oxygen consumption by a 70 kilogram male, 40-year-old male at rest, which is 3.5 ml per kg per minute.
Okay. So very good. Now, correct answer. Now, if you look at the activities that the Duke Activity Index does, they are kind of arbitrary. We call it a self-assessment by the patient. The patient is saying, yes, I can do it. Are there any other better, more objective methods by which you can assess the functional capacity of a patient?
Yes, ma'am. We can do cardiopulmonary exercise testing in order to objectify.
Very good. And
Then stress echo, stress ECG.
No. I'm just talking in your examination.
Examination.
Apart from your cardiopulmonary exercise testing, for that you need a whole equipment, machine, and everything. A very
6-minute walk test.
Yes, very good. 6-minute walk test. You should never forget. These are very important things that you must always answer in your Viva. These are very useful tests. They're objective tests, and they give a better assessment of your functional capacity. Now, you might just say that when you talk about things like cardiopulmonary exercise testing, and stress echo or stress ECG, they have very significant concerns of precipitating an ischemic attack in a patient with a CAD. So it's very important to remember whenever you're doing such testing, there should be continuous ECG monitoring while doing cardiopulmonary testing, as well as frequent blood pressure monitoring whenever you're taking a patient for cardiopulmonary exercise testing. Right? So this is a very important point that should be considered. Now, coming to the investigations, you have been answering very well. Good job. In investigations, yes, you said 12-lead ECG, but that may not be enough. You may need to have a better evaluation, because ECG sometimes does not give a complete picture. It has only 60% sensitivity, right? So an echocardiography becomes a very important investigation in these patients. And what can you tell me about stress ECG, what was previously known as TMT? Would you like to go for this in this patient?
No, ma'am, I would not go for this.
Why?
Because my patient METs is greater than 4, and his risk index for major adverse cardiac event is less than 1%. So according to guidelines, there is no need for further cardiac evaluation for my patient.
Which guideline are you quoting?
Ma'am, ACC/AHA 2014 guidelines.
Okay, so you see, we understand that the guideline does say that you are not supposed to go for stress ECG. However, that also depends upon the type of surgery that you're going for. Always keep that in mind. So here for this surgery, yes, you're very correct when you're saying that, but the investigations have to be titrated to two things: the risk of surgery and the cardiac risk, both. Okay, so then we go to echocardiography. What about echocardiography? Would you like to go for an echocardiography in this patient?
He has his old echo report, so I think it's of 6 months ago he has taken.
Okay,
I
so
think
would you
that
like
will
to repeat it?
No, ma'am.
Very good. So if there is no fresh changes, report within 1 year is acceptable. You only go for a fresh echocardiography. Excuse me. In a patient who has either a dyspnea of unknown origin, a heart failure patient whose dyspnea gets worsened, or a patient who was clinically stable, who had no previously documented LV dysfunction, with previously documented LV dysfunction. Can you tell me the echocardiography report of this patient? Can you put that up?
Anji, ma'am.
Do you have it?
Yes, ma'am, I have it.
Right.
It was taken on May 22, and he had normal chamber dimensions. Regional wall motion abnormality was present in the anterior wall. Mild mitral regurgitation. He had ejection fraction of 40 to 45%. Grade 1 left ventricular diastolic dysfunction, and no clots or vegetations were seen.
Okay. So what do you mean by ejection fraction?
Ma'am, left ventricular ejection fraction. Cardiac output. Cardiac output.
It's not cardiac output.
Ma'am, volume of blood ejected by the ventricle during systole.
Stroke volume. It is the stroke volume upon the end diastolic volume.
Okay.
Now, it is very important all of you to understand that ejection fraction is a number which can be extremely misleading indicator of LV function. Now, when I'm saying that it is the fraction of stroke volume upon end diastolic volume, now how that becomes very important. If the patient has a low end diastolic volume, which happens classically in HOCM. You know what is HOCM? hypertrophic obstructive.
Obstructive cardiomyopathy.
So in that patient, what's going to happen? Because of the hypertrophy, the end diastolic volume per se is low. Patient has a good contractility, the stroke volume is good. So we have a falsely high ejection fraction. Does that ejection fraction give you an indicator of LV function? It does not. So one has to look at ejection fraction as a ratio where both the numerator and denominator can affect the value. Always remember this. Now this becomes extremely important in a patient with a valvular abnormality. Very often you will come across echo of 40%, and you're thinking, okay, 45%, 40% patient, it's a big mess. Patient is not responding well because what is happening in the mitral regurgitation? The mitral regurgitation is that's making the valves incompetent. So what is happening here is that the heart is trying to push out the blood, eject out the blood. Some is going out, and the some of the blood is falling back into the Am I audible?
Yes, ma'am. Now you're audible. Yes, ma'am. Sorry, we lost your connection in between.
When did you lose my connection? I was just going on speaking.
Ma'am, you started to talk about mitral regurgitation.
Happening. So basically, we have to understand that in valvular lesions, also because the blood then comes back, there is a change in the end diastolic volume and the stroke volume. So you will have the fraction will not remain the same because the end diastolic volume becomes more and your stroke volume remains the same. So what is happening? The numerator is the same, the denominator is more. So the value is now falsely
Hi.
Am I audible?
Numerator is more, denominator is less.
Numerator is less, denominator is more. So what is going to happen? You will have a
False, low value.
So when the regurgitation becomes lesser, the EF raises. So I'm just trying to make you understand that there are more factors. There are two factors. It is the numerator and denominator, both that are affecting the ejection fraction. You should, and it is favors whole is 45. My patient is going to fare well. If my ejection fraction is 25, my patient is not going to fare well. Now look at grade 1 diastolic dysfunction. What does that mean?
Ma'am, the ventricles are not able to pump out all the blood. So
no, what is okay? Your ejection fraction is giving you this systolic function, right? It is a indicator of the left ventricular systolic function. What does the diastolic function tell you?
ma'am, it is a ratio. It is also a ratio. It is early by late diastole will be calculated.
So it is very important to understand that the diastolic dysfunction usually precedes the development of a left ventricular systolic function, and it is an indicator of the it's a very strong predictor of the left atrial function actually, because of the left, it's like when you look at left, when you look at the left ventricular end diastolic volume, whereas diastolic function is a measure of the left end diastolic pressure. It's a surrogate for your left atrial volume. So it tells us two things. It tells us whether the patient will be able to tolerate the preload well or not. If a patient has a grade 1 diastolic or a grade 2 diastolic dysfunction, the patient will be having trouble in handling the preload. And it is also a predictor of development of atrial fibrillation in these patients. So just remember, grade diastolic dysfunction becomes very important for us, for the anesthesiologist more than for the cardiologist, because we are the ones who are handling the fluid shift. So this becomes an extremely important factor for us to look into. All right. Are you with me on that?
Hanji.
Okay. So what are the other types of things we talk? You can tell me about?
I'm sorry, I didn't hear you, ma'am. Can you repeat? Sorry.
Is my voice cracking?
Ma'am, it's better now. It's better now.
Okay, I will try to change my connection also.
Hanji, ma'am.
My connection is showing very good strength, but I will still try to change the connection.
Okay, ma'am. Ma'am, it's better now.
It's better now?
Hanji,
Okay.
ma'am.
Okay, so now my question was, what are the other types of preoperative cardiac investigations? Would you like to go for any other preoperative cardiac investigations? Not in this patient, but in any other patient.
And we can ask for a stress ECG, stress echography if
Yes.
needed.
Yes.
Then we can ask the old angiogram report which my patient has. That may be indicative.
Yes, very good, very good. One should always ask for so that you come to know. Then recently, a few more advanced testing has come out. One is cardiac MRI. With with the advent of COVID, now more and more cardiologists are going for cardiac MRI, and they feel that it is a very good technique to assess wall motion abnormalities in ischemic patients, and they give you a specified location of the myocardial perfusion. Then similarly, nuclear cardiac imaging, that is also coming up in a big way. So these are two things. If you're asked in the exam, what are the recent changes, what are the recently preferred investigations? So the nuclear cardiac imaging and cardiac MRI are two investigations that are gaining a lot of popularity amongst cardiologists. In fact, a lot of patients post-COVID were diagnosed to have myocardial insult by cardiac MRI when stress echo and ECG were failing. Okay, tell me one thing. Would you like to go for a biomarker estimation in the preoperative period?
Yes, ma'am. We can ask for cardiac BNP level and NT-proBNP level also.
Which one would you prefer?
Ma'am, NT-proBNP.
Why so?
Ma'am, actually, the level of NT-pro and BNP rises 3 to 4 times more than BNP level, even for a small infarct or a failure. So it is more sensitive when compared to BNP.
Go for a NT-proBNP preoperatively.
Ma'am, again your voice cracked. I'm sorry.
So what are the patient? Can you hear me now?
Ma'am.
Which is the patient profile in which you would like to go for a preoperative biomarker estimation?
I'm patient with history of congestive heart failure, or we can ask patient with a recent MI or posted for very high risk surgery. We can ask for biomarkers.
So you see, no, there are specific indications for this. Routinely, neither is a pro-NT-BNP or a troponin testing recommended. However, in high-risk patients, like patients who have METs less than 4, or with an RCI index of 1, if you are going for a vascular surgery, or an RCRI index of more than 2 for a non-vascular surgery. Now, these are the indications where this is the patient profile in which you will go for a preoperative biomarker estimation. In 2017, a few more indications were added, which are easier to remember, which is that patient with an age more than equal to 65 years of age, RCRI more than equal to 1, or age between 45 to 64 years, but with significant cardiovascular disease. So it is recommended that in this profile of patient, that is age more than or equal to 65, RCRI 1 or more, age 45 to 64 with significant cardiovascular disease, these are the patients in which you will go for as well as troponin before as well as 48 to 72 hours after the surgery. So this is very important to know, as can be asked very easily in your exam. These are important, very important points to know.
Okay.
Right. So how would you like to, what would your patient be in, would you like to do a risk stratification for your patient?
Yes, ma'am.
What
Ma'am,
risk, what be his RCRI index?
ma'am, my patient RCRI score is 1.
Yes, good. So tell me, what are the other which are the other ways by which you can do?
Ma'am, again, sorry, I lost your connection.
What is the full form of RCRI?
Ma'am, revised cardiac risk index.
Yes, very good. And what are the other risk indices that are commonly used?
Ma'am, others we can use American College of Surgeons NSQIP scale, National Surgical Quality Improvement Plan. Then
Yes.
we have Gupta's MICA risk index.
Okay. So what is the advantage of one over the other?
Ma'am, the other two are web-based tools and it has more number of parameters compared to
But
RCRI.
they are more sensitive and they tend to be, you can stop your screen sharing now. You can, you don't need to see anything. But the advantage of this is that they are more surgery specific and they are much more sensitive tools. Okay. So now we have to take up this patient for TEP. What will be your preoperative advice in this patient?
Yes, ma'am. First, ma'am, I can't see. Ma'am, first I will write consent. Written informed consent should be taken.
You will
Then
take
I
a
will write.
final consent in this patient?
Ma'am, I will inform the risk associated with the surgery. Also, risk of perioperative MI should be explained to the patient.
So
And,
what is the risk involved in this surgery? Not perioperative MI and?
ma'am, there may be risk of ventricular fibrillation. There may be cardiac arrest, pulmonary edema.
Arrhythmias, congestive heart failure. So we are looking at three very important things that you must understand: perioperative MI, perioperative CHF, and perioperative arrhythmias, and we should be ready to take care of them. Very good. So we have taken consent. Next.
I'll write NPO orders.
Okay. Next.
Then I will add I'll tell the patient to continue his antihypertensive medications on day of surgery.
So what antihypertensive is the patient on?
Currently he's on beta blocker. Then he's taking angiotensin converting enzyme. Then he's also
enalapril also.
Then he's on antiplatelet drugs, clopidogrel, which should be stopped 5 to 7 days before surgery. I will tell him to stop. Then statins can be continued on the day of surgery with sips of water.
Okay. Now you wanted to continue your ACE inhibitor.
Yes, ma'am.
So what can you tell me about the latest recommendations regarding ACE inhibitors and surgery?
2016 ACCHA guidelines, it tells like it is reasonable to continue AC-ARB inhibitors on day of surgery unless we expect massive fluid shift or we expect sudden episodes of hypotension in the surgery. It is not advisable.
Very good, very good. And it has been now a lot of literature contributes that hypotension because of the ACE inhibitors is usually very responsive to fluids, so it can be easily tackled. and the risk of the cardiac risk of withholding is much more. Very
No.
good. Right. So supposing the patient was not on beta blockers, would you like to start the beta blockers?
Yes, ma'am. I will start and target heart rate 60 to 80 beats per minute. However, I will start it at least 1 week before surgery.
Not 60 to 80. What are you saying?
60 to
Target
70.
is not, it's 50 to 60 beats without
50 to-
significant hypotension.
Okay. Okay, I'm sorry.
Right. And when will you like to start?
Ma'am, at least 1 week before surgery, I would like to start.
So there is a lot of controversy on that, but most literature says that 2 to 7 days before, it should be not started acutely. It should be started at least 24 hours before elective surgery. And beta blockers are very useful drugs because they have anti-ischemic, they have antihypertensive, and they have antidysrhythmic properties. So they should be continued and they should not be stopped. And all most controversial and very, very confusing part is your dual antiplatelet drugs. There's a lot of, let us try to clarify the, air regarding that. Now, what are the types of antiplatelet drugs that are available? Can you just tell me briefly about those?
Yes, ma'am. First, we have COX-1 inhibitor, which will inhibit thromboxane 8-2, that is aspirin.
Okay.
Then we have P2Y12 receptor inhibitor, which is ticlopidin, clopidogrel, prasugrel. Then we have GP2B3A inhibitor, which is apixaban, eptifibatide, and tirofiban. Then we have platelet protease activated receptor inhibitor.
A simpler way to remember is whether by their mode of action. So we have irreversible blockers and platelet blockers, and we have the reversible ones. So in the irreversible, we have your aspirin, your clopidogrel, your prasugrel, and reversible becomes your cangrelor and your ticagrelor. It is very important to know through their mode of action more than anything else. And what is available in your setup is also extremely important. And why did you say that we need to omit them for 5 to 7 days before surgery? Why not 2 to 3 days?
Ma'am, because lifespan of the platelet is 5 to 7 days. So the drug will be acting till the platelet is alive.
Right. So 80% will have recovered their normal function by the time, because new platelets are being formed. So this works for all except for one drug. The 5 to 7 rule works for all except for any drug which is a longer duration of action. Prasugrel. Right. So, and when do you need to stop prasugrel?
7 to 10 days before.
So 10 days. 10 days is what we need.
Okay.
Now, any drug that which has a shorter duration of action and that can be used, as a bridging therapy.
We can use cangrelor. It has very short duration of action.
Which is usually, what is the duration of action?
Ma'am, 4 to 6 hours.
So it needs to be discontinued?
Yes, ma'am. 6 hours prior surgery, at least 6 hours prior surgery.
Yes, it needs to be discontinued 6 hours, and its duration of action is around time from last dose to offset of action is just 60 minutes. It's not 6 hours. So okay, you take a duration of, right? So if you need to do a bridging therapy, then your drug of choice becomes
cangrelor.
Very good. So when you are looking at stopping dual antiplatelet, what all factors are you looking at?
Ma'am, I will check whether my patient is more prone for bleeding or he is more prone for thrombosis. And I have to look whether it is a low risk surgery or high risk surgery. Then
how do you classify a surgery as a high risk or a low risk?
Any surgery into vascular compartment or a major abdominal cavity will be termed as high risk surgery. and low risk surgery will involve superficial lesions. Excision of superficial lesions will be low risk surgery.
So you look at another factor also when you're looking at stopping a DAPT. You very correctly said you look into the risk of bleeding, the risk of thromboembolism. You also look into, very importantly, what is the urgency of the surgery. Okay, that becomes a very important factor too. Right? So can you define what is an urgent surgery, what is an emergency surgery? Is there any difference between an emergency surgery or an urgent surgery?
Emergency surgery should be done within 24 hours. Within 6 hours. Sorry, urgent surgery is less than 6 hours. Emergency is up to 24 hours.
And time sensitive is this when we can allow delay of up to 1
6
week
weeks.
to allow for evaluation. 1 to 6 weeks for evaluation. Right?
Okay.
So this is also what we have to look into when we are looking at discontinuation of DAPTs. Now, supposing it's a emergency surgery, right? And patient has had a stent, say, just 2 months back. Then, would you like to go ahead with the surgery?
Ma'am, if it is an emergency surgery, I will discuss the risk benefit with the surgeon. And if should be proceeded, I will proceed only, taking care of. Ma'am.
Will you stop your DAPT?
No, ma'am, I'll consider bridging therapy if the risk of thrombosis is more.
What do you mean by bridging therapy?
Ma'am, I will withhold the antiplatelet at least 5 to 7 days before surgery and before
So
3
it's
days.
an emergency surgery. You're getting
Okay, emergency. Ma'am, I will proceed only.
Okay, let me make things easier for you. Let's talk about elective surgery first, then we'll talk. Now, supposing if the patient has had months with the surgery. Sarvanan, can you hear me?
Ma'am, now only I can hear you. Sorry again.
Yeah, so I'm saying you have a patient who is posted for an elective surgery.
Yes, ma'am.
It's been 2 months since a drug-eluting stent has been placed. Would you like to go ahead with the surgery?
No, ma'am, I'll postpone the surgery for at least 6 months.
Okay. If the patient, like in your patient, it's been what, 11 months?
Ma'am.
Can you go ahead for an elective surgery?
Yes, ma'am, I can proceed with the surgery.
Very good. Now, what would you like to do for your DAPTs? Would you
Ma'am,
like
to stop the DAPT before surgery?
Both aspirin as well as?
No, ma'am. Aspirin can be continued in the perioperative period.
Regardless of the timing of surgery, the guidelines recommend continuing at least aspirin throughout the perioperative period and ideally continuing DAPT unless the surgery demands discontinuation. So you can stop your clopid, but aspirin should be continued. And when can you resume your clopid?
Ma'am, after 24 hours, after surgical hemostasis has been achieved, we can restart clopidogrel.
Yes. And it is important to remember that that time you go for a loading dose, not the dose with which the patient was previously taking, because there has been a break now. You have to give the loading dose, right?
Okay.
So, for how long should you delay an elective surgery?
After drug-eluting stent, 6 months at least. After 6 months, minimum of 6 months.
It has been now changed. It is important to remember that. Okay, right. So this is regarding your elective surgery. Now let us think of a situation where we are going for a emergency surgery. Shall we talk about an emergency surgery now?
Thank you.
Right. Patient comes with, say, a strangulated hernia. The same patient comes with a strangulated hernia. Patient is on DOPT. What will you do?
Ma'am, I will explain the perioperative risk of bleeding. Then I will continue with the surgery only, and I'll assess the risk benefit with the surgeon if he wants to proceed.
Of course, we have no other option but to continue. This is an emergency surgery. It's a strangulated bowel. What will you do about your DAPTs?
Ma'am, patient would have already taken the dose, so I will continue with the surgery. I will ask to arrange platelets during the intra period if needed. Then I will proceed with the surgery.
Patient had taken his aspirin and clopid a day before. Today morning he has not taken anything. He is nil per oral. So that becomes 1 day gap for you. Okay. Now supposing this was a patient who had a high risk of bleeding, then what will you do? It was some other surgery. Patient comes with an emergency surgery with a very high risk of bleeding. Then what will you do?
We can transfuse platelets before surgical incision.
Very good. Anything else to do?
We can
very
ask
simple
for
thing is to give
Ma'am?
Trenexa.
हाँ जी मैम,
Tranexamic acid. Is there any timing that's important?
Sorry ma'am, you stop.
When will you prefer to give platelets?
Ma'am, before surgical incision, at least before.
No. Before the surgical incision, or is it correlated with the time of intake of your drugs?
Sorry ma'am, I don't know the answer.
Not to time it with the surgical incision, but with the time since the patient took the your DAPTs. So if you are planning to give platelet transfusion, that you make sure that at least 2 hours has elapsed after aspirin and 12 to 24 hours after clopid. Some literature says after 4 hours, but there is universal agreement on this that their platelet transfusion is most effective when given after 12 hours. Mind, otherwise you are just simply wasting your platelet infusion, right? So we have a lot of clarity now about how we are going to be proceeding with your DAPTs and when will we be timing our surgery. Well done, good job on your answers, Sarvanan, keep it up. Now tell me, now that you're all set to take up this patient for surgery, what will be your anesthetic goals? What will you keep in mind when you're giving anesthesia? We are assuming general anesthesia.
My main goal is to maintain the myocardial oxygen supply and demand ratio. So I will avoid any tachycardia or bradycardia, hypotension or hypertension. I will maintain normothermia. I will maintain normocapnia.
Excellent. So tell me, what is your induction agent of choice?
I will like to go with etomidate 0.2 to 0.6 mg per kilogram. So IV induction.
Very good. And what else will you take care during induction?
During induction, I will slowly give the drug and titrate it according to the patient.
And
then laryngoscopy should be gentle, less than 15 seconds, and I can attenuate the pressure response to laryngoscopy with drugs such as lignocaine, esmolol.
What is the dose of lignocaine?
Ma'am, 1.5 mg per kg, at least 90 seconds before intubation.
Very good. And what else? You can use lignocaine. What else can you use?
I can give esmolol. Then other beta blockers like labetalol, metoprolol. Magnesium sulfate also can be.
Not recommended. No, labetalol is not recommended. What are you saying?
Metoprolol.
Why do you want to give long acting for something that's going to last, an episode that's going to last few minutes? You never give long acting, you only give esmolol. Tell me some other agents that attenuate the pressure response to laryngoscopy.
Magnesium sulfate 40 milligram per kg can be used.
Okay.
And we can use induction agent like propofol 10 to 20 mg bolus at least 10
You
to
want to
15.
first use etomidate, not use propofol, and then you want to use propofol. You can deepen the plane of anesthesia bioinhalational agents,
हाँ जी.
right? You can use nitrates. You can use calcium channel blockers.
Okay.
Right. So in maintenance of anesthesia, what would you prefer? An opioid-based anesthesia or an inhalational-based anesthesia? Would you prefer a TIVA or would you prefer inhalational-based? What would be your choice?
In my institute, we use inhalation inhalational maintenance only. We will use mixture of oxygen, nitrous, and sevoflurane for maintenance of anesthesia, topped up with opioids, with bolus of opioids.
If given the choice, what would you prefer and why?
Inhalation agents. Ma'am, as such, there's no preference for TIVA or inhalation agent.
Opioid is supposed to be most hemodynamically stable. Opioid-based anesthesia is supposed to be most hemodynamically stable, but if your institute is giving inhalational agent, I'm sure they must be doing it with a reason. So you see that both have their pros and cons. Opioid-based anesthesia has its con of providing excellent hemodynamic stability. But with inhalational agents, we have something which is called ischemic preconditioning. Are you aware of what is ischemic preconditioning?
Yes, ma'am.
What is that?
It is a process by which a part of myocardium can be rendered resistant to ischemia by a brief period of occlusion of the vessel.
Yes, very good. The myocardium remains protected after a period after withdrawal, even of the stimulus. This is called memory of preconditioning. So this is a wonderful way to safeguard the patient who is a patient of coronary artery disease. And there has been extensive work that has showed that volatile agents actually protect the heart from ischemic myocardial injuries. So this will become a very important beneficial benefit in our patients. Okay. So now you've understood why we prefer inhalational agents. Now, what all monitoring would you like to go for in the intraoperative period?
I will use standard ASA2 monitors, ECG monitoring, blood pressure monitoring, pulse oximetry, temperature monitoring, and end-tidal carbon dioxide.
What would you look? How would you use your ECG?
ECG, preferably 5-lead ECG will be used for this patient, and lead 2 and lead 5 should be monitored continuously in the perioperative period.
Yes. So you have to look at lead 5 becomes a very important lead for us. Go for ST segment analysis. That is very important that you make sure that you have your ST segment analysis is on. And what are you looking for here? What are you looking for in the ECG?
Ma'am, I will look for perioperative rhythm disturbances. I can look for new onset ST elevation, ST depression.
Okay, very good. Now, supposing you do land up with, a significant ST segment change, what are you going to do now?
First, I will see whether it is associated with any hemodynamic instability.
Very good.
Then I will I will titrate my FiO2 so that I will target saturation greater than 95%. Then
listen, your saturation, there will be no change in saturation with an ST segment. Your patient is not hypoxic. Saturation is 98, 99. Everything is fine, but you have an ST segment change, a significant, more than, say, 2 mm change.
Okay, ma'am.
So you very correctly said you will take care of your hemodynamics. You will make sure that any hypertension or tachycardia, if there is present, is corrected, because that is probably causing the insult. Then rather than increasing the oxygen, you will rather deepen the plane. If you increase the oxygen FiO2, you don't need it. That is not the problem. The problem is your hypertension and tachycardia. You've got to make sure the depth is adequate. So you will give either inhalational agents or opioids or beta blockers, whatever you need, and you will deepen the plane of anesthesia. Now you deepen the plane of anesthesia, your hypertension is also corrected, the BP has come to normal, the tachycardia is also settled. but now your changes are persisting. What will you do next?
Then I will give good analgesics and opioids. I can give opioids.
Opioids you've given. I'm saying we've already deepened. You've given opioids. No better than nothing. No analgesic better than opioids. Ischemia is persisting. What will you do? You've read about intraoperative STEMIs. So you will add something that increases the blood supply to the heart.
Nitrates. Nitrates, we can start the patient on nitrates.
Okay, you will add nitrates. Very good. So this is how what can happen. If you have any specific arrhythmia, you will take care of that arrhythmia as per the standard treatment modalities. Now, tell me one thing, apart from the standard ASA monitoring, would you like some other monitoring?
Ma'am, my patient is of low risk category, so I will continue.
Supposing a patient was a major risk, major surgery with a lot of fluid shifts and all.
I will go for invasive arterial line monitoring.
Very good, very good. You can go for invasive arterial blood pressure, CVP. Where all would you like to go for a pulmonary artery catheterization? Any specific indication for pulmonary artery catheterization?
We can have it for a patient of a known case of congestive heart failure. Or,
yes, and patients on everything else will fail. Your CVP will not be a good guide in a patient with a cardiomyopathy. So in those patients, we go for a pulmonary artery catheterization. Very good. Excellent. Right? So you can also go for a transesophageal echocardiography. It's very helpful in high-risk patients. And it helps to detect ischemia, any ventricular dysfunction and fluid status. Also, can you come to know through TE and you come to know of it very fast. So it's a very good intraoperative monitoring when you have high-risk patients with major surgery, right? So you've managed your case fine. Extubation, anything you would like to take care of during extubation?
Yes, ma'am. Again, I wanted to avoid any tachycardia or hypertension during extubation.
Right. So
we can again supplement with the short-acting opioids during extubation, and I will have a smooth extubation.
So, we are always worried about two things at the time of extubation. We want a smooth extubation, but we also want at the same time that the patient should wake up awake with, good reflexes and good spontaneous respiration. So at that time, it is a good idea that you can use short-acting beta blockers like esmolol, right? So that will take care of the hemodynamics and also give you an awake patient. So that becomes a better choice. And we don't have opioids like remifentanil. If we had remifentanil, then yes, we could have used those. But for us, as of now, a beta blocker like esmolol may be a better idea. So what all post-op advice will you have for your patient?
Ma'am, post-op, I will write adequate analgesia should be maintained. Then normothermia should be maintained even in the post-operative period. Then I will, if patient is a high risk, I will also advise continuous ECG monitoring also in the post-operative period if available.
It is not available. It is mandatory to have continued ECG monitoring in the post-operative period for such a patient.
Okay.
And you know the reason for that? Why I'm emphasizing on that?
Ma'am, because perioperative MI is also very common.
The most common time when a patient will have MI is not in the intraoperative period. It was generally
in the post-operative period.
In the first 48 hours. So this is a very critical time for you. And at this time, you must have a patient who's pain-free, well-oxygenated, warm patient who is undergoing continuous vigilant monitoring. Now, when you say pain-free, you yourself said good analgesia. I'm also saying good analgesia. It has the advantage that it will not cause hypertension and tachycardia, but it has the disadvantage that because of good analgesia, sometimes a patient, the post-op MI can be missed. So thus the need for a continuous ECG monitoring in these patients. Now, okay. Can you tell me what is MINS, MINS, myocardial injury after non-cardiac surgery?
Yes, ma'am. It is defined as signs of myocardial ischemia associated with rise in serum troponin levels greater than 99th percentile. There should be rise and fall, and also there will be evidence of myocardial infarction like ECG changes, Q waves in ECG, ST elevation or depression, or in echocardiography, patient may have wall motion abnormality.
So MILS is basically a very unusual situation where you will have troponin elevation, but the classic signs and symptoms or even the ECG findings suggestive of ischemia may not be present.
Okay.
So this is what is different from myocardial infarction in the postoperative period. Now, this is mostly, as I said, it's a silent injury, and it is very strongly associated with mortality. And the risk factor for this is not your hypertension and tachycardia. It is the intraoperative and postoperative hypotension, which is associated with MINS.
Okay.
So again, there is a lot of controversy that should you be doing a postoperative troponin surveillance? Should you be doing routinely monitoring of troponin of patients who are cardiac patients who come for non-cardiac surgery? So are you
Routinely not needed, but for high-risk patient, if the patient has any signs or symptoms of ischemia, we can order a troponin level.
So, but again, as I said, we will not have signs and symptoms of ischemia in MINS. To rule out MINS, what the latest recommendation says is that post-operative troponin surveillance should be done when you have, if the patient had an elevated NT-proBNP in the preoperative period. That means these are the patients who will need a troponin surveillance in the post-op. When your RCRA index is more than equal to 1, age greater than 45 years with significant cardiac disease, and age more than 65 years. So this is what the newer recommendations are coming up. They are yet to be validated. However, these are ones that we have to keep an eye open and be vigilant about these kind of complications that happen in the postoperative period. Supposing this patient refused to go for a laparoscopic surgery and said that, no, I want an open surgery. Now, we can go for regional anesthesia in this patient or not? And how will we proceed?
Yes, ma'am, we can proceed with regional anesthesia in this patient. And I will stop again clopidogrel at least 5 to 7 days before surgery, and he will continue aspirin. Then I will go for combined spinal epidural anesthesia for this patient for giving central neuraxial blockade.
Why so?
So that I can also cover the post-operative pain management also with the epidural top-ups.
So I was very happy with your answer when you said CSC, but I was not so happy with your reason. Now that I would have been happier if you had said that with a CSC, I can give a smaller dose of the drug initially. I can titrate the level in a better manner. I have the flexibility of then increasing the block if required and giving post-operative analgesia, because I do not want a hypotension in my patient. I don't, as you yourself said, you don't want either a hypotension or a bradycardia, hyper or tachycardia. So that gives you a lot of control, a lot of flexibility. So this is the reason. And of course, post-operative pain relief is also a very, very big advantage. Now, supposing you did land up with a postspinal hypotension, then what would be your vasopressor of choice in this patient who is a cardiac disease patient?
Ma'am, I will use phenylephrine boluses for this patient.
Why not anything else?
Phenylephrine is a vasoconstrictor. It will not increase the heart rate, so I will prefer phenylephrine.
What are you routinely using in your hospital?
We have mephenteramine in my hospital.
Very good. So do we. We are all using mephenteramine. What is the problem with mephenteramine?
Mephenteramine also causes tachycardia, so I want to avoid.
Does it? Does it cause tachycardia?
Little.
Little. So yes, mephenteramine can also be because we need vasoconstrictors. We basically don't want to use ephedrine. So we can use this too. Phenylephrine has its own share of problems. So as I promised Sujali, I have to hand over to her. So well done, good job. You answered well, and I hope the students got some good learnings from there. Over to you, Sujali, for wrapping it up. We'll take
Thank you.
the questions in the end, after Sujali's talk is over.
Okay.
Good afternoon, everyone. I'll be talking in brief about the perioperative management of a patient with coronary artery disease for non-cardiac surgery. So ischemic heart disease or coronary artery disease is a condition characterized by inadequate supply of blood and oxygen to a portion of the myocardium. It is essentially a mismatch between the oxygen demand and supply at the level of the myocardium, resulting in impaired function. It may present as a stable angina, wherein the patient has angina on exertion but is relieved by rest or by medication. And they may also present as acute coronary syndrome, which includes unstable angina, ST elevation MI or non-ST elevation MI, or patients may present with sudden cardiac death. Now, the incidence of perioperative MI is reported to be 1 to 17% in all types of surgery and is an independent risk predictor for cardiovascular death. Now, patients experiencing MI in the perioperative period after a non-cardiac surgery have an in-hospital mortality of 15 to 25% and highest being in the first 30 days. Now, the exact mechanism of perioperative MI is uncertain, but acute plaque disruption and myocardial oxygen supply demand mismatch are the two important mechanisms contributing to perioperative MI. So when there is a plaque rupture, there will be platelet aggravation resulting in activation of coagulation cascade with subsequent generation of thrombin, leading to partial or complete occlusion of coronary artery. So the factors which may lead to imbalance in the supply demand may be decreased oxygen supply, which may be caused by decrease in the coronary blood flow, as in tachycardia, hypotension, hypocapnia, coronary artery spasm or coronary artery blockage, or it may be due to decrease in the oxygen content of blood, as in anemia or hypoxia, or because of reduced oxygen availability to the tissues when there is a leftward shift of the oxygen dissociation curve. And there may be increased oxygen demand in the perioperative period due to tachycardia, hypertension, increase in the ventricular wall tension, increased preload, increased afterload, increased myocardial contractility, or in patients with hypothermia. Now, the goals of preoperative evaluation in these patients will be to determine the extent of ischemic heart disease or any other previous interventions the patient might have received, like PCI or CABG, and to decide on further testing and to treat the modifiable risk factors and to review the medical therapy the patient might be receiving and plan the management of cardiac illness during the perioperative period and to plan our anesthetic technique. Now, preoperative evaluation, we will focus on the history and physical examination of the current complaints the patient has come with the extent of the disease, whether the patient requires emergency surgery or whether the surgery can be delayed, and evaluation of the pre-existing ischemic heart disease, the current condition of the disease, the severity, whether what treatment the patient has received before, whether the patient has any stent or the patient has undergone CABG, the current medications the patient is receiving, whether we need to modify the treatment or whether patient needs to be optimized. And we need to evaluate the patient for any comorbid conditions, like if the patient has diabetes, if the patient has hypertension or any renal disease, whether they need to be optimized or whether any medication needs to be modified. And we need to assess the functional capacity of the patient. This will help us in stratifying the risk of the patient and help us in deciding whether the patient needs further workup. So this can be done by asking the patient about the daily activity tolerance of the patient with meds, or we can use specific activity scales like Duke Activity Status Index. So if the patient can climb 2 flights of stairs or can walk on a level ground at 4 miles per hour, we consider the patient to have more than 4 meds. And this patient will have a good or good to moderate exercise tolerance and will be able to tolerate surgery and anesthesia. And the next is the risk stratification of these patients. There are various risk stratification models. One is the revised cardiac risk index, which is commonly used. This utilizes 6 independent risk predictors to define the risk of major adverse cardiac events during the perioperative period. So these are coronary heart disease, congestive heart failure, cerebrovascular disease, stroke or transient ischemic attack, insulin-dependent diabetes mellitus, patient with renal insufficiency with serum creatinine of more than 2 mg per deciliter, and patients undergoing high-risk surgery like suprainguinal vascular, intraperitoneal or intrathoracic surgeries. So another risk stratification model is given by the American College of Surgeons, that is the NSQIP, MICA, and surgical risk calculator. They use 21 variables and provide a more comprehensive assessment of surgery-specific risk of major adverse cardiac events and death. However, it is more complex and requires a web calculator, and it has not been validated outside the study population. The risk stratification model given by 2014 ACC/AHA guidelines is they have categorized the patients into 2 groups, that is elevated risk and low risk. Patients with more than 2 RCRIs are considered to have an elevated risk for major adverse cardiac events of greater than 1%, and with low risk, patients' risk is less than 1% for MACE and comprises of patients with less than 2 RCRIs. Now, what will be our approach to patients regarding investigations in the perioperative period? So for 12-lead ECG, recommendation is that patients who undergoing low-risk surgical procedures need not do a 12-lead ECG, but patients with known CAD or other structural heart disease and patients who are asymptomatic but presence of clinical risk factors will need a 12-lead ECG. Now, echocardiography, that is assessment of left ventricular function, will be required in patients who have dyspnea of unknown origin or heart failure with worsening dyspnea or left ventricular dysfunction who have not been assessed in the last 1 year. Preoperative exercise stress testing or pharmacological stress testing is not recommended for patients undergoing low-risk surgery and for patients having functional capacity of more than 4 meds who are undergoing high-risk surgery. Preoperative stress testing may be undertaken for patients with unknown functional capacity or functional capacity of less than 4 meds who are undergoing high-risk surgery if it will change the perioperative management. Now, this is the ACC 2014 ACC/AHA guidelines for preoperative evaluation of patients undergoing non-cardiac surgery. So the first step is we have to decide whether the patient requires emergency surgery or not. If the patient requires emergency surgery, then patient has to be assessed for the risk, and then we proceed for surgery. Next, if the patient does not require emergency surgery, then we have to assess whether the patient has any significant or unstable cardiac condition. If yes, then we have to evaluate and treat according to the existing practice guidelines, and non-cardiac surgery may be delayed. If the patient has no significant or unstable cardiac condition, then we estimate the perioperative risk of major adverse cardiac events in these patients. If the patient belongs to the low risk category, that is risk of less than 1%, then no further testing is required and patient can proceed for surgery. If there is an elevated risk of, that is risk of more than 1%, then we assess the functional capacity of the patient. If the functional capacity of the patient is more than 4 meds, then no further testing is required and the patient can proceed for surgery. But if the meds is unknown or less than 4, then we have to decide whether the patient requires will further testing affect our decision, surgical decision, or the perioperative care? If no, then we proceed for surgery according to the existing practice guidelines, or we consider alternative strategies of management. And if the further testing will modify our management, then we need to the patient may undergo pharmacologic stress testing, and if it is normal or mildly abnormal, the patient can proceed for surgery. But if there is significant abnormality, we may consider the patient for coronary revascularization. Now, indications for coronary revascularization in the perioperative period will be according to the existing clinical practice guidelines in non-surgical setting. They are high-risk coronary anatomy, example, left main disease, or patients presenting with unstable angina or myocardial infarction or life-threatening arrhythmias due to active ischemia. So the perioperative concerns with patients who have undergone a coronary revascularization will be the consequences of delaying the desired surgical procedure and the risk of thrombosis and bleeding. Now, so the timing of elective non-cardiac surgery, this has been updated in the 2016, according to the 2016 ACC/AHA guidelines. So elective non-cardiac surgery should be delayed for 60 days following an episode of myocardial infarction without coronary revascularization, and 14 days following balloon angioplasty, 6 weeks after coronary stent bypass grafting, and at least 30 days following a bare metal stent, and at least 6 months following a drug-eluting stent implantation. The previous guidelines, that is according to the 2014 guidelines, were 4 to 6 weeks for bare metal stents and at least 1 year for drug-eluting stents. Now, preoperative drug therapy in these patients. Patients who have this type of patients will mostly be getting antiplatelets. So according to ACC/AHA guidelines, patients who are receiving low dose aspirin, that is 75 to 100 milligrams, has to continue taking aspirin, and they have to discontinue antiplatelets, that is P2Y12 inhibitors, clopidogrel and ticagrelor, at least 5 days, and prasugrel at least 7 days before surgery, and clopidogrel should be restarted as soon as possible after adequate surgical hemostasis, like maybe preferably 1 day after the surgery with a loading dose of clopidogrel. Now, initiation or continuation of aspirin is not beneficial in patients undergoing elective non-cardiac, non-carotid surgery who have not had previous coronary stenting done, unless the risk of ischemic events outweigh the risk of surgical bleeding. And there is no convincing evidence regarding the efficacy of bridging with either intravenous antiplatelet or anticoagulant therapy. So if the patient has to go for a bridging therapy, if the clinician wants a bridging therapy, then we can aspirin has to be continued, and after the stoppage of the oral antiplatelets, patient can be considered for cangrelor infusion, that is to be started at least 2 to 3 days, can be started 2 to 3 days after stopping the oral antiplatelet with an infusion of 0.75 mics per kg per minute, and continued up to 1 day or 6 hours prior to the surgery. And it can be restarted after 6 hours of surgery after assessing the risk of bleeding. And if the patient is allowed orally, then we can go for loading dose of clopidogrel. Now, other therapy the patient will be receiving are beta blockers, which will help in reducing the myocardial oxygen consumption, improve the coronary blood flow, and improve the supply-demand ratio. So the recommendations by ACC/AHA are that beta blockers should be continued in patients who are taking them chronically, and they may be initiated in patients with elevated cardiac risk, such as ischemia during the preoperative stress testing, or in patients with 3 or more RCRI risk factors. And if beta blocker is initiated, it should be started long enough in advance and at least more than 1 day before surgery. Nitrates decrease the left ventricular preload, decrease the left ventricular afterload, and improve coronary circulation and prevent or reverse coronary spasm. Prophylactic intravenous nitroglycerin is not effective in reducing myocardial ischemia in patients undergoing non-cardiac surgery. Patients already on nitrates for anginal therapy may continue using them. Now, calcium channel blockers reduce myocardial oxygen demand and also improve the coronary blood flow. So ACHA gives no recommendations regarding calcium channel blockers, but according to the European Society of Cardiology, they may be continued in the perioperative period because they help in reducing the perioperative cardiovascular risk. Perioperative statins, they help in lowering lipids, stabilize the coronary plaque by decreasing lipid oxidation, inflammation, matrix, metalloproteinase, and cell death. ACHA recommend the continuation of statin therapy in patients currently taking statins, but perioperative initiation of statins may be considered in patients undergoing elevated risk or vascular surgeries. Now, regarding AC inhibitors and ARBs, there's a continued controversy regarding withholding angiotensin converting enzyme inhibitors and ARB 24 hours prior to surgery, because these agents may lead to intraoperative hypotension in patients being chronically treated with them. ACHA recommend continuation of AC inhibitors or ARBs perioperatively unless the surgical process involves major fluid shifts or significant blood loss. If AC inhibitors or ARBs are held before surgery, it is reasonable to restart them as soon as clinically feasible postoperatively. Now, the goals of anesthetic management will be to prevent myocardial ischemia by avoiding factors that increase myocardial oxygen demand or decrease myocardial oxygen supply, and to monitor for ischemia and to treat them if it develops. For pre-medication, we can go for benzodiazepines because they will help to decrease anxiety-induced tachycardia and hypertension. And for the choice of anesthetic technique, there is no difference between general anesthesia and neuroaxial anesthesia techniques with respect to perioperative cardiac morbidity or mortality. Now, the current ACC-HA guidelines recommend the choice of anesthetic technique be left to the discretion of the anesthesia care team. Now, for intraoperative monitoring, we will go for ECG with monitoring of lead 2 and lead V5 because they are more sensitive, and also use of computerized ST segment analysis. And also BP will be, we can go for a non-invasive BP or invasive BP depending on the cardiac function of the patient and also the risk of surgery. And end-tidal carbon dioxide, SpO2, temperature monitoring, and urine output. Pulmonary artery catheter is not recommended routinely, and TE may be used in patients who are at high risk for developing myocardial ischemia and who are undergoing major non-cardiac surgery. Now, the goal during the intraoperative period will be to minimize hypotension and sympathetic stimulation during induction and tracheal intubation. The induction agent of choice is etomidate because of its better hemodynamic profile, and we should give induction agents slowly in small incremental doses to prevent hypotension. And ketamine should be avoided as it causes sympathetic stimulation. And muscle relaxant will be cardiostable muscle relaxants like vicuronium, cisatracurium, or rocuronium, and pancuronium should be avoided because of its vagolytic effect. And during laryngoscopy and tracheal intubation, laryngoscopy should be gentle, lasting for less than 15 seconds, and we may use agents like opioids, lignocaine, and beta blockers to attenuate the stress response associated with laryngoscopy and tracheal intubation. For maintenance, studies have found no difference in MI rates in patients receiving volatile anesthetics and those receiving total intravenous anesthesia. CHA recommend the use of either of these agents, with the choice being determined by factors other than the prevention of perioperative MI. And use of nitrous oxide is not associated with increased risk of cardiovascular mortality or morbidity. Now, During the intraoperative period, we have to maintain hemodynamic stability, avoid hyperventilation, prevent hypothermia, provide good analgesia and depth of anesthesia, and normal volemia should be maintained with IV fluids and blood transfusion where indicated. During reversal and extubation, we can use medications like lidocaine and beta blockers to reduce the sympathetic stimulation associated with extubation. Now, concerns with regional anesthesia will be aspirin and other non-steroidal anti-inflammatory drugs appear to represent no added risks for development of spinal hematoma in patients having epidural or spinal anesthesia. Clopidogrel may be reinstituted 24 hours post-operatively and resume 6 hours after catheter removal. Hypotension resulting from sympathetic blockage should be controlled and promptly treated. Now, post-operative management of this patient is very crucial as most of perioperative MI occur early after surgery, that is 0 to 4 days, and 90% occur within 7 days. And a continuous ECG monitoring and BP monitoring is required in these patients. Serial 12-lead ECG and troponin measurements are useful in patients at high risk of developing ischemia. These patients should be given supplemental oxygen and maintain hemoglobin levels, and blood transfusion should be done where indicated. Analgesia should be adequate and provided with IV agents like paracetamol or NSAIDs or opioids, or we can go for regional blocks or epidural analgesia. And we should maintain normothermia because hypothermia and shivering triples the incidence of adverse myocardial outcomes in high-risk patients. And so if there is a high-risk suspicion of perioperative MI, we can diagnose this. First is we need a high index of suspicion for at-risk patients. Then if the patient has any clinical signs and symptoms of ischemia, then we can go for a 12-lead ECG, wherein we will find STT segment changes or new left bundle branch block, and measurement of biomarkers of cardiac injury, especially the cardiac specific troponin, will help us identify patients with perioperative MI. And management of perioperative MI, we should provide supplemental oxygen to these patients, analgesia with opioids like fentanyl or morphine, and nitrates, beta blockers, and aspirin. And if there is, after assessing the risk of bleeding, we can go for P2 vital inhibitors or glycoprotein 2B3A inhibitors, and also unfractionated heparin or low molecular weight heparin if indicated. And if weighing the risk of death or bleeding, we have to consider the patient for PCI or CABG intervention procedures. So these are my references. Thank you.
Thank you, Dr. Sujali. Very comprehensive presentation. We have a couple of questions in the chat box. The first question is how to manage intraoperative MI in this patient. I think we have already discussed it both during the case presentation as well as in Dr. Sujali's presentation. And we have also, I think Dr. Sujali has covered the guidelines about beta blockers preoperatively. Dr. Sujali, maybe if you could put up that slide once, I think that should be good enough. I can't see any other questions.
These are the only two questions that we have.
Yeah. So either nobody was listening or we were really good.
I'll go for the second one.
Well, you have always been very charming. Right. So should we wrap up or should we wait? I'll leave that to the organizers.
We can wrap up. I think in case we have any questions, we can just engage on us. Any of us can sort of.
Yeah, they please, the students are most free to call. You can, share my email ID with them and they can mail me their queries. I'll be more than happy to answer anything.
Thank you so much.
Thank you.
Thank you, ma'am.
Thank you, ma'am.
Well done. Good job.
Thank you, ma'am. It was a pleasure hearing you after so long, and a wonderful case discussion, very informative, and I'm sure everyone would have loved it.
I hope so.
A topic that we all are very scared of, but you just simplified it and you just went on right to the basics of it, so that it was easy to understand for all the postgraduates. Thank you.
Thank you. It's been a pleasure. Thank you.
Thank you, ma'am. Moving on to the next session, I would like to introduce the chairperson for this session, Dr. Lalita Chaudhary. Ma'am is Director Professor at APPEC2023 and Dr. RML Hospital, and ma'am's area of special interest are critical care and pediatric anesthesia. We welcome you, ma'am, and I hand over the proceedings of this session to you, ma'am. And can you unmute yourself and you can unmute and switch on your camera. Ma'am, you're still on the mute.